Hi, my name is Brian Verbicus. I am a PGY1 pharmacy resident from the University of Vermont Health Network, Champlain Valley Physicians Hospital. Today I'll be discussing a little bit about some of the recent data that has emerged regarding the use of IV alteplase beyond the traditional 3 to 4.5 hour time frame in the setting of acute ischemic stroke. By the end of the discussion today, you should be familiar with the basic pharmacological profile of alteplase, including absolute contraindications to alteplase use. We'll look at some key recommendations from the 2019 AHA-ASA updated stroke guideline, and then we'll look at two more recent trials that have come out, the Extend and the Wakeup Trial. We'll delve into these, look at the methodology, results, limitations, clinical implications, and then just discuss some of the takeaways from both of these trials. So alteplase is a recombinant form of endogenous tissue plasminogen activator. What it does is it binds to thrombus-bound fibrin and converts any plasminogen that's entrapped within the clot, converts it into plasmin, which initiates local fibrinolysis, thus degrading any existing clot. It's indicated for use in acute ischemic stroke as well as pulmonary embolism and ST elevation myocardial infarction. In acute ischemic stroke, dosing is a standard 0.9 milligrams per kilogram with a max of 90 milligrams. 10% of this dose is going to be given as a bolus over 1 minute, and the remainder will be infused over the ensuing 60 minutes. When we use IV alteplase, the most common adverse effects we concern ourselves with is bleeding. In clinical trials, about 15.5% of patients actually experience intracranial hemorrhage when given IV alteplase. You should also be familiar with some of the absolute contraindications to IV alteplase therapy, particularly in the setting of acute ischemic stroke, which we'll go over on the next slide. So this slide lists out all of the absolute contraindications to alteplase in acute ischemic stroke. Anybody who has intracranial hemorrhage on imaging, symptoms suggestive of a subarachnoid hemorrhage, those who have any history of intracranial hemorrhage, a 3-month history of neurosurgery, head trauma, or stroke, patients presenting with uncontrolled hypertension, a systolic being greater than 185 or a diastolic blood pressure greater than 110, suspected or confirmed endocarditis, and then patients with certain known bleeding diatheses are considered contraindicated if they have platelet count less than 100,000, heparin use within 48 hours, and an elevated APTT, currently using warfarin and have an INR greater than 1.7, or current use of a DOAC or direct thrombin inhibitor. These patients are considered to be contraindicated to alteplase therapy. So moving on now to the 2019 updated stroke guideline. This first slide here is just used to demonstrate that regarding the time window for IV alteplase, our recommendations really have remained unchanged since the last iteration of the guidelines in 2013. The first recommendation here, we know that IV alteplase has best clinical outcomes when given within 3 hours of ischemic stroke symptom onset. And for the second recommendation, we do know that we can extend this window up to 4.5 hours in certain patients and still have that benefit. This third recommendation here is a new recommendation seen with the 2019 stroke guideline update. It focuses on the use of IV alteplase in patients who either awake with stroke symptoms where we can't pinpoint the exact time of onset of symptoms, or those presenting potentially beyond the 4.5 hour window and not really knowing when symptoms actually started. So using certain imaging techniques, we can select patients who may have a benefit from IV alteplase in this setting, and we'll talk about the certain imaging techniques and we'll talk about the data behind this throughout the presentation. So the first trial that we're going to take a look at today regarding this new recommendation is the Wakeup Trial, which was MRI-guided thrombolysis for stroke with unknown time of onset. This was published in August of 2018 and is the current study that they cite in the new recommendation in the 2019 stroke guideline update. So looking at the methodology of the Wakeup trial, it was a randomized, blinded, parallel assignment. It was a multi-center trial in 8 European countries and included 70 different sites. Patients were included if they were presenting with clinical signs and symptoms of acute stroke. They had to be able to perform activities of daily living prior to stroke. Their last known well had to be greater than 4.5 hours before presentation. The big one here was these patients were selected based on imaging criteria, certain imaging criteria they had to meet. So on an MRI, DWI imaging, which is diffusion weighted imaging, they had to have an abnormal sign or positivity, and they had to have essentially no abnormal signal or no involvement based on the MRI flare imaging, which is fluid attenuated inversion recovery. And what this is known as is a DWI flare mismatch. So this is how they selected patients for inclusion in the study. Patients were excluded if they had any evidence of hemorrhage on an MRI, if they had larger lesions that were larger than 1/3 of the area of the middle cerebral artery. They also excluded any patients who were candidates for thrombectomy, those with severe stroke, particularly those with a National Institute of Health stroke score greater than 25, and then any patient who had a contraindication to alteplase therapy was excluded. So as far as the intervention, patients either receive placebo or they receive the standard dose of IV alteplase for stroke. Looked at a number of different outcomes, with the primary efficacy outcome being favorable clinical outcomes at 90 days, which they defined as a score of 0 or 1 on the modified ranking scale. They had 2 primary safety endpoints, which were a composite of death or dependency at 90 days, which encompassed a score of 4 to 6 on the modified ranking scale, and they also looked individually at death at 90 days. So just a little bit about how these patients were actually selected based on imaging criteria. We used 2 different scans, magnetic resonance imaging scans, or techniques, the diffusion weighted imaging, or the DWI, and the fluid attenuated inversion recovery, or FLAIR. And what studies have shown us is that in patients who are presenting within roughly 4.5 hours of stroke onset, their DWI will show positivity or tissue involvement, where their FLAIR imaging will essentially show negativity or no parenchymal involvement. So we use this to kind of pick what patients are presenting roughly at about the 4.5 hour since stroke onset. Even though we may not know when the symptoms actually started, using this imaging criteria, we can essentially, with pretty strong confidence, select those patients who are most likely presenting within 4.5 hours of true stroke onset. So moving on to the baseline characteristics. So in the end, 503 patients were enrolled in this trial, 254 being in the alteplase group, and 249 were randomized to placebo. Overall, there were no differences between the 2 groups. They were evenly matched at baseline as far as the characteristics that we took into account. There was one exception in the alteplase group. There was a higher rate of intracranial occlusion in the internal carotid artery. So just kind of an overview of the patients that are included in this trial. Average age, somewhere around 65 years old. The majority of patients were male. 90% of the patients included in this trial had awoken from nighttime sleep and had stroke symptoms of unknown onset. Um, they knew that they happened sometime between falling asleep and waking up with symptoms. Um, for most of these patients, the last known well was about 7 hours prior to recognizing the symptoms, and the large majority of these patients had mild to moderate stroke based on a median National Institute of Health stroke scale score of 6. So looking at the results, the primary efficacy endpoint of favorable outcome, which again was the score of 0 or 1 on the modified Rankin scale at 90 days, was greater in those treated with alteplase versus those treated with placebo. So 53.3% in the alteplase group versus 41.8% of the placebo group achieved favorable clinical outcomes at 90 days. And this was statistically significant. In addition, they looked at a number of secondary efficacy endpoints, all of which, the ones listed below here, did reach statistical significance, including median score on the MRS at 90 days. They looked at a correlation between treatment response at 90 days and then baseline level of deficit based on the MRS score at baseline. Global outcome score at 90 days, they looked at a quality of life survey, the EQ5D at 90 days, as well as a specific area on the EQ5D, the visual analog scale at 90 days, all of which alteplase group had better outcomes compared to the placebo group. Looking now at the secondary efficacy endpoint of the MRS score at 90 days, we can see in the figure down below the distribution of scores between the alteplase and placebo group. Again, the alteplase group had an average score of 1, where the placebo group had an average score of 2, and you can see it by the table on the right there, the correlating description or severity of deficit based on the score, with a 0 being no symptoms at all and 6 being death. Looking at the primary safety endpoints, so the death or dependency, which was defined as a MRS score of 4 to 6 at 90 days, showed no difference between the alteplase and placebo group. In addition, there was no difference in death at 90 days between the two groups. However, when you look at the data, there were numerically more deaths in the alteplase group compared to placebo. There's 10 in the alteplase group versus 3 in placebo, although this didn't reach statistical significance. 4 of those 10 deaths in the alteplase group were attributed to subsequent symptomatic intracranial hemorrhage. As far as a secondary safety endpoint, there was also no statistical significant difference in symptomatic intracranial hemorrhage between groups. However, similar to death at 90 days, we can see that there was a numerically more symptomatic intracranial hemorrhage in the alteplase group, no matter what definition that they considered. There were several limitations with this trial. It was stopped early due to lack of funding because they weren't able to reach their anticipated sample size as quickly as expected. Their funding was essentially terminated. So this brings into the question whether or not we're able to interpret and draw conclusions from the outcomes and the results that we saw in the trial. There were numerically more deaths and symptomatic intracranial hemorrhage seen in the alteplase group compared to placebo. However, it wasn't statistically significant in this trial. One can speculate that if they did reach their anticipated sample size and had a larger patient population, this difference may have become statistically significant. There was also some question as to the generalizability of the results of the trial. Most of the patients in the trial had presented with a mild or moderate stroke based on their National Institute of Health stroke scale score, the median score being a 6, and excluding those with severe stroke with a score greater than 25. Additionally, a large aspect to consider is that The imaging techniques used in the trial to select patients for enrollment in the trial really aren't readily available or performed at many institutions. So again, this brings it into the question of the practical application and the generalizability of the methods and the results of this trial. Another interesting consideration is while the Wakeup trial was underway, two other trials were actually published, the Dawn and the Diffuse 3 trials, that showed in patients who were receiving thrombectomy in the extended time window, these patients actually had improved outcomes compared to those who did not undergo thrombectomy. The authors of the Wakeup trial determined that about 20% of their patients would have actually qualified for thrombectomy in these trials, where these patients may have had a benefit had they undergone thrombectomy. However, in the Wakeup trial, again, they excluded any patient who was a candidate for endovascular therapy. So as far as the clinical implications of the trial, so in the Wakeup trial, patients with unknown time of stroke onset who had a DWI flare mismatch and were treated with IV alteplase had significant improvement in functional outcomes with no significant increase in the risk of death or a major bleed. Again, like we discussed, even though it wasn't a statistically significant difference, there were numerically more deaths and symptomatic intracranial hemorrhage seen with the IV alteplase group. As we discussed earlier when we looked at the 2019 AHA-ASA updated stroke guideline, our current guidelines have been updated to reflect the results of the Wakeup trial. So now we're going to take a look at our second trial of the day, the Extend trial, or thrombolysis guided by perfusion imaging up to 9 hours after onset of stroke. This trial was published back in May of 2019. The Extend trial was a multi-center, double-blind, randomized trial. It included patients who were 18 years of age or greater with hemispheric acute ischemic stroke, who were able to receive treatment within 4.5 and 9 hours after stroke onset. Patients were also included if they awoke with stroke symptoms, so long as the time from the midpoint of sleep to the time of symptom recognition was less than or equal to 9 hours. We also included patients with a NIH SS score of 4 to 26. In addition, like the Wakeup trial, these patients were also selected based on imaging criteria. So these patients had to have hypoperfused but salvageable regions on the brain detected by automated perfusion imaging. And this could either be CT perfusion imaging or perfusion diffusion MRI. Patients were excluded if they had intracranial hemorrhage on any imaging, if their symptoms were rapidly improving, if they were a candidate for endovascular therapy, so similar to the Wakeup trial, these patients were excluded. Those who had a pre-stroke MRS score of 2 or greater, any contraindication to contrast agents or TPA use were excluded. And then lastly, patients who had an ischemic core that was greater than 1/3 the size of the middle cerebral artery were also excluded from this trial. As far as the intervention, same intervention that we saw with the Wakeup trial. It was either standard dose IV alteplase or placebo. As far as the primary outcomes, the primary efficacy outcome in this trial was the MRS score of 0 or 1 at 90 days. And we had two different primary safety endpoints, being death at 90 days or symptomatic intracranial hemorrhage. So a total of 225 patients were eventually enrolled in the Extend trial, 113 being in the alteplase group and 112 in the placebo group. No major differences between the two groups at baseline, but when you take a look at our population as a whole, average age roughly 72 years old. Most people in this study had a moderate stroke based on their National Institute of Health stroke scale score. The average score was 12 in the alteplase group versus 10 in the placebo group. So these patients had more severe stroke when we compare that to the Wakeup trial. Additionally, as With the Wakeup trial, we saw about 90% of patients were awakening from sleep with stroke symptoms, so they had unknown onset of stroke symptoms, whereas about 65% of patients in this trial are awakening from sleep with new onset stroke symptoms. Lastly, about 70% of patients in this trial had large vessel occlusion. With regard to the primary efficacy endpoint, which again was a modified Rankin scale score of 0 or 1 at 90 days, in the adjusted analysis where they adjusted for patient age, severity of stroke based on NIHSS score, as well as baseline MRS score, more patients in the alteplase group actually achieved this outcome when compared to placebo. As you can see in the unadjusted analysis, however, there was no difference between groups with regard to this outcome. Looking at the primary safety endpoints, there was no difference between groups when it came to death at 90 days. However, when we look at symptomatic intracranial hemorrhage within 36 hours after treatment, although it wasn't statistically significant, there were numerically more occurrences of symptomatic intracranial hemorrhage in the alteplase group when compared to placebo. When we look at some of our secondary efficacy endpoints, there was no difference in functional improvement at 90 days based on MRS score between the two groups. However, when we look at functional independence, which was defined by an MRS score of 0 to 2 at 90 days, significantly more patients in the alteplase group achieved this outcome compared to placebo group. So again, there were a number of limitations with the Extend trial. Like we saw with the Wakeup trial, the Extend trial was also stopped early. This time, while the Extend trial was ongoing, the results from the Wakeup trial were published, and due to the positive results that we saw in the Wakeup trial, the ultimate decision was made to terminate the Extend trial early. They had only enrolled about 73% of their planned sample size, so they did not achieve their pre-specified power. So again, this takes into question our ability to draw conclusions and interpretations from some of the results we saw in the trial. Another interesting aspect of the trial is they found no difference in functional improvement at 90 days when they looked at alteplase versus placebo. However, in previous trials, alteplase has consistently shown functional improvement based on MRS score improvement at 90 days. So why this outcome wasn't seen in the Extend trial remains unknown. There were also several unadjusted analyses for primary and secondary endpoints that, even though the adjusted analysis may have shown statistical significance, the unadjusted analyses did not show any difference between groups. Kind of like we talked about with the Wakeup trial as well, a lot of these patients had large vessel occlusion, and from what we know now based on the Diffuse 3 and the Dawn trials, a lot of these patients may have qualified for thrombectomy and thus may have had further improvement in outcomes had they underwent thrombectomy. However, like in the Wakeup trial, these patients were ultimately excluded. And lastly, just another caveat, in the Extend trial, the door-to-needle time was about 2 hours, which isn't typically ideal for administration of TPA in the setting of acute ischemic stroke. So the Extend trial demonstrated that in patients with acute ischemic stroke who had favorable perfusion imaging profile, when treated with IV alteplase between 4.5 to 9 hours after symptom onset or upon awakening with stroke symptoms, compared to placebo, the alteplase group had a higher percentage of patients with no or minimal deficits at 90 days based on an MRS score of 0 or 1. In addition, these patients had experienced more symptomatic intracranial hemorrhage within 36 hours after treatment initiation when compared to placebo. As we discussed earlier, our 2019 stroke guideline update does not yet reflect what we saw with the Extend trial, so it'll be interesting to see in the next iteration of the guidelines how they look at the Extend trial and if it changes recommendations at all. So when we look at the Wakeup and the Extend trials, both trials do suggest a potential benefit for IV alteplase therapy beyond our traditional 4.5-hour window in the setting of acute ischemic stroke. Our current guidelines, however, really only consider use of IV alteplase in certain patients based on very specific imaging criteria. So again, these patients have to be selected based on a DWI to flare mismatch on MRI. To me, the risk versus benefit, however, of alteplase in these patients still remains uncertain, even though we did see clinical improvement and some benefit in terms of some of the clinical outcomes we looked at in these trials. There were some safety concerns with even a potential increase in death in these patients, and we saw more intracranial hemorrhage in those treated with alteplase. Overall, when we look at the methodology and how these patients were selected, we need to think about the practical application of these methods into practice. A lot of institutions either don't readily perform this sort of imaging or may not even have it readily available to be performed. So the ability to extend the findings of these trials into the general population remains limited. So that will conclude our discussion for today. If you do have any questions, concerns, comments about anything we discussed today, anything I went over in the presentation that isn't clear, feel free to shoot me an email. My email is listed on the first slide of the presentation, and I'll be sure to get back to you for that. Thank you for your time, and thank you for listening.